Generally, there are two types of transplants. Autologous transplants, also called autotransplants, when we use the patient's own bone marrow or stem cells to rescue them from high doses of chemotherapy, and allogeneic transplants, or allotransplants, when we use a donor bone marrow to treat the patient.
There are some diseases that we routinely treat with autologous transplants and other diseases that we routinely treat with allogeneic transplants. So it really just depends on what the patient has and what the circumstance is.
Autologous transplants are given for cancers where the cancer can be cured simply by increasing the doses of chemotherapy higher than what could be safely given in their doctor's office. We give them so much chemotherapy that all the normal cells in their bone marrow are wiped out.
You go in ahead of time and have your stem cells pulled out of your blood, and they're stored, and then you're given high-dose chemotherapy, which usually kills your bone marrow, and so then you're given your own cells back to kind of reseed those.
For autologous transplants, where the transplant procedure really involves high doses of chemotherapy, the recovery time is measured in weeks to months. And the biggest risk after undergoing an autologous transplant is the cancer is going to grow back.
But for diseases that involve the marrow, it oftentimes is not useful or feasible to do the autologous transplant.
For example, we know with AML that if we use a patient's own stem cells, that the likelihood that the disease is going to come back is much higher than if we use someone else's stem cells.
So we turn to a donor transplant, an allogeneic transplant, where we have the benefit of donor immune cells that can also enter the body, seek out and destroy any residual leukemia cells. For patients who need an allogeneic bone marrow transplant, we can collect donor stem cells from a brother or sister who has the same HLA matched. They're related by being in the same family. Or we can collect bone marrow or stem cells from a volunteer donor who by chance has the same HLA match, but they're unrelated.
We can also use cord bloods, which are umbilical cord blood units that were frozen when a baby was born and that we can use sometimes for transplants. Or occasionally we will also use an adult haploidentical, which means a half-matched donor who's either a sibling or a parent or sometimes even a child.
For transplant to be successful, the patient's immune system must be reduced so new bone marrow stem cells can grow in the bone marrow and produce new blood cells.
Their immune system's going to be completely wiped out and they're going to be at risk for any kind of infection, just like a brand new baby.
So in the allotransplant, we are actually transplanting the immune system of the donor into the patient, and there's a period of adaptation that has to occur there. And that period can be anywhere from a few months to a number of years.
I usually tell patients who undergo an allogeneic transplant not to expect to go back to work for about a year.
After the first year, after I was off of all of the anti-rejection medications, and then I got off of the pain medication, that was when I started to realize, okay, this is real. Okay, Constance, you gotta learn yourself again. And then probably a couple months after that, after a year, probably like a year and 3 months, year and 4 months, I was like, okay, we're good. You're good. You have a life now.